Good evening and welcome to this evening's live event. I'm Dr. Steve Parker and it's my pleasure to be your host for the next hour or so. Tonight we'll be talking about managing challenging clinical scenarios, and I'm thrilled to be joined by exactly the sort of brains trust you'd want to have for this sort of discussion, the expert team from Dental Advice Network. Now with me in studio we have specialist endodontist Dr. Omar Ikram, clinical pharmacist Adjunct Associate Professor Geraldine Moses AM, and Consultant Cardiac Anaesthetist Dr. Manu Iyer. Now also joining us remotely we have Professor Ian Myers, OAM, and Oral Medicine Specialist Dr. Amanda van Leeuwen. So welcome everyone. Now this evening we have a lot of ground to cover, but we definitely want to interact with you throughout the event. So please send us your questions or comments and we'll answer as many as we can. So to kick things off, I'm going to go to our favourite endodontist, Dr. Omar Ikram, and you've got a couple of interesting things to talk to us about.
That's right, Stephen. Basically, we're going to talk about fractured files. These cases come up quite a bit in endodontics because rotary instruments, when we're learning to use them, obviously we're testing the limits of the instrument and how you're going to test that if you don't fracture a few. And if you do endo, you're going to fracture files. So fortunately, these can be removed, but they present a problem to our cleaning of the root canal. They're basically an obstruction. You can see here I'm removing a file in this video, but you need good magnification and illumination and ultrasonic tip, and this is a constant problem, and also it can basically present a restorative issue for our cases because we have to remove tooth structure to remove the files. Mm-hmm. You can see I was able to remove this one, but you can see in the previous slide the dentist had not protected the tooth against fracture, and when the instrument had fractured they'd panicked, dressed the tooth and referred the case, but the patient lived 4 hours away, and basically they could be a few weeks before they come and see me, and then obviously the tooth could fracture, and then when it fractures that's more of a problem than the fractured file in the tooth. We do actually have an app for dentists, the EndoPrep app that William Haar and I released a few years ago, and it does contain information on fractured files and hypochlorite accident and other things, perforations. We have 50,000 downloads, so this is free to download for dentists. So what are the causes of fractured instruments? Well, cyclic fatigue, which is the situation where the file binds on the canal walls and it rotates and gets phase transformations, and there's fracture of the file after a certain number of phase transformations. When the file becomes locked in the root canal and binds and then it rotates, that's called torsional failure, and that's a common way to fracture files. Also, these usually going on at the same time with the instrument fracture. Basic management of fractured instruments will involve informing the patient, taking radiographs to document where the file is present. If it's visible in the coronal part of the root canal, it might be able to be removed. In the middle, it might be able to be bypassed. And at the apex, maybe we just have to accept the fact that we can't remove it. The prognosis of the case depends on when the file was fractured. So if we get a good glide path and irrigate the root canal system, we first of all reduce the torsional load on the next file, but we also clean the root canal, and that helps to disinfect the canal. And if the file fractures, then we have a disinfected root canal with a file fracture, and it's not as bad as if the root canal was blocked and it was infected. Referral is the obvious situation, and asking the Dental Advice Network on what to do is another good thing to do. How do we avoid it? Well, as I said, we create a glide path before we start using rotary files, lubricate the root canal with irrigants, watch for loaded files, and attend courses. Tell the patient, obviously, when you fracture a file, the prognosis depends on what stage the instrument fracture occurred. Offer an opinion and maybe cover the consult. To get an opinion from an endodontist, contact your indemnity. And the good news is if you were able to clean out the root canal and fracture the file, then usually that's okay, and the prognosis is improved. In this case, I was sent the patient after they'd had a hypochlorite accident. This is the preoperative radiograph of tooth 2-3. You can see there's a large radiolucent area in the root canal space, and the tooth has been accessed. So I was thinking a few things when I saw the pre-op radiograph. Where's the root canal? And where's the apical periodontitis? I can't see a lesion there, and the reason why is because in upper anterior teeth a lot of the time is the root apex is actually close to the cortical plate, and you don't lose much bone when the apex is inflamed. So we did a cone beam scan. There's the apical periodontitis, so this was not the wrong tooth that the dentist had accessed. There is apical periodontitis there. You can see the canal is clear as day, so there is a patent root canal under that perforation that you can see in the 2D image, and there's the perforation. Buccally, which is the normal place to perforate. Unfortunately, the patient had had a hypochlorite accident as well. I was able to locate the canal then easily, which was palatable to the perforation, and then clean it out. I had to use chlorhexidine for the irrigant because the patient wouldn't let me near them with hypochlorite, but that was just for the first visit after I dressed the root canal and closed the perforation. They were happy with me using hypochlorite, and I filled the root canal. And you can see there's the post-op and 12-month review radiographs. So why is perforation actually a problem? I mean, we have apical foramen at the apex of teeth. I used to always think to myself, isn't there lots of little holes in the root canals? The answer is that it's a problem because you're removing hard tissue, which is there to keep the tooth strong and resistant from fracture. It also creates a defect, so it's a funny shaped defect which we can't then fill, and it also presents a problem for bacterial products exiting the root canal. You're creating another pathway of exit for them. Root canals treatments are really great when the tooth is sealed after disinfection, but if there's an open area, that encourages fluid in and also bacterial toxins out. And basically, it obviously creates a path for hypochlorite accidents in the future. So this is the main reason, and obviously repair of these is possible, but if they're a large perforation, maybe sometimes the tooth has to be removed. So what do we tell the patient when we have had a hypochlorite accident? Well, you tell them that the cleaning fluids come out of the root canal and it's irritating. Again, contact your indemnity, ask the Dental Advice Network team here. We have over 175 years of dental experience between all of us. I'm sure we can come up with a good answer. And if you feel it's beyond your ability, then refer to the appropriate practitioner. A maxillofacial surgeon is often a helpful person to refer to.
Okay, Omar. Well, thank you very much for that. Look, we've had a few questions come in already. I'm going to go to one here we've just received. I couldn't progress past a point in a mesial root of an upper molar. I was concerned it might be a ledge. How do you navigate it? Basically, he's saying, how can you distinguish between a ledge and a blocked calcified canal, and how would you manage that?
That's a very good question. I mean, usually what happens with a blocked canal is that you usually have got a canal that you're working on, and then all of a sudden it's now closed. With a ledge, it's fairly similar, but usually with a ledge you've been using aggressive instruments and pushing, and you will know there's a difference. So the best way you can progress, I find, is actually use a lubricant in the canal like EDTA and maybe some stiffened files like C-Pilot or C+ files. I actually run courses on how to use these files because the C+ files cut and they can be quite stiff, and so it's important to master the technique, and once you master the technique, that'll help you bypass ledges. The other thing that commonly happens in upper molars in the mesiobuccal root is that there has an MB2 canal which you can sometimes use to bypass the ledge, and then that can sometimes join the MB1, which is ledge. That's a little trick that we often use. So in those cases, the MB2 canal, which is often the cause of failure, can actually be our friend. So there are a few situations where we can overcome these difficulties. That's one for a course for sure.
Okay, so I think the answer is attend one of Omar's courses and you'll certainly find out the answer to that question. Look, thanks Omar, that was wonderful. I'm now going to ask Professor Geraldine Moses to have a chat to us about a couple of interesting cases that you've been asked about in the past, a couple of interesting questions.
Yeah, thanks Steve. It's great to be here, and thanks everyone for joining us tonight. As many people may know, I ran the Pharma Advice Service for the ADA for 13 years, and during that time I've been presented with a lot of complex, tricky cases. Just as a bit of background though, I think people should be aware that as a pharmacist working with the dental profession, one of the big things that I can help people with is understanding why pharmacists do what they do. And why do they reject your prescription? Why do they get all cranky when you want to order drugs for your practice? And the rules on that are all about the legislation about drugs. So I can always answer your questions about the legal things behind drugs and prescribing, but also it comes down to things like drugs in pregnancy and lactation, drugs in pediatrics and geriatrics. I've had lots of complex questions about aged care and dentists now practicing in aged care facilities. But one that comes up over and over is pain management. And so the first case I'd like to share is about a tricky thing that came up in a pain management question. So it was a 22-year-old female who was had 4 impacted wisdom teeth removed, and she was calling the day after that saying, I'm still in pain. She'd been prescribed Panadine Forte and amoxicillin, the usual thing that dentists prescribe, and it wasn't working. And this situation comes up. I know for a lot of you watching tonight, they'll say, yes, that happened to me, because people will have all sorts of excuses for why the usual drugs don't work. I'll actually give a whole lecture on that if you're ever interested. But the things that occur to people will be, what else can I prescribe? Should I move on to oxycodone, tapentadol, tramadol? As many of you would know, I hate that drug. And could she be a drug seeker? Could she be actually sneakily asking for naughty drugs? So when the person asked me for advice, I, of course, came back with more questions and said, tell me more about the patient. Indeed, what's her medical background, her medical history, and is she on any medicines? Well, it turned out she's on the oral contraceptive pill, a magnesium supplement, don't care, but she's also on duloxetine. That's Cymbalta is the brand name. And I asked the dentist had they considered drug interactions as a reason for why the codeine wasn't working, and they went, what are you talking about? So I suppose this is the sort of thing that we all need to make sure we're up to date on, that many antidepressants can inhibit the metabolism of codeine. You should all know by now that codeine is just morphine in disguise. It gets converted to morphine in the body, and that's how it confers its analgesic effect. But if your body is prevented from doing that conversion, then the codeine will give no analgesia. You may get that from a drug, but you also might get that from your own genes, that your own body genetic makeup could be the reason why you can't convert codeine to morphine. And that's why actually we don't like codeine very much anymore, and why therapeutic guidelines does emphasize using oxycodone instead of codeine these days. So just as a bit of a refresher, I know how much everyone likes seeing chemical structures and metabolic pathways, but just to remind you that codeine is converted via an enzyme called CYP2D6 to morphine. The thing is then you've also, if you're prescribing codeine, you have to remind yourself that you're prescribing codeine, but you're also prescribing morphine. So you need to also understand the pharmacokinetics of morphine itself, and the fact that it gets broken down to M6 and M3 glucuronides, and the M6 is neurotoxic. So it's a pretty nasty drug, and also very short acting, because morphine itself only lasts about 3 hours, and yet we prescribe codeine more like 6th hourly. So it's a very well-known drug interaction that if you impair that metabolism, the codeine won't work, and that could be a very common reason why your patients say, I'm still in pain. And duloxetine is a very commonly prescribed antidepressant. It's not just used for depression, it's also used in the management of musculoskeletal pain, fibromyalgia, all kinds of other unusual indications. So you'll see it out there. I'd like to also remind you that tramadol is also subject to this metabolic pathway, that it's a pro-drug too, that the drug you swallow is not the drug that works, so it's got to be converted just like codeine does. So it also is a pretty dumb drug to use because of this metabolic limitation, and that's why therapeutic guidelines we prescribe oxycodone, because it's the drug you swallow is the drug that works. Just on the slide you can see that I've listed some of the commonly used drugs that are out there that can block CYP2D6 from getting in there to convert codeine to morphine. Even things like cannabidiol, which is CBD, you may know it as one of the ingredients in medicinal cannabis. Diphenhydramine. Diphenhydramine is an antihistamine. It's in Benadryl, the well-known cough mixture in Australia. In the US, it's used for every blooming thing you can think of, very popular antihistamine. But it also blocks CYP2D6. And Ritalin, very commonly used for treatment of ADHD. So there are lots of drugs out there that can stuff up codeine. So, this and many other things are why patients will come to you sometimes and saying, you prescribe me Benadryl, but it doesn't work. And they might come across as if they're drug seekers, but actually it could be that just what you prescribed is not a very clever thing. And I guess we need to also remind you that most dental pain is inflammatory in nature. So adding in an anti-inflammatory probably would be a more preferable regimen for managing her pain anyway. And don't use the codeine in the first place. And remember, it's simultaneous paracetamol and ibuprofen, not alternating. Alternating is very 20th century. And this is a mnemonic that I use. Actually, the mnemonic's not there on the slide, but a list of questions to ask people when they come back to you saying what you prescribed isn't working, that you should triple check things like what did they actually take. This is such a pharmacy thing, but people will say, oh yeah, I took ibuprofen and paracetamol, and you go, and you might be on the phone, but get them to bring the packages to the phone and they'll go, oh, it says aspirin, or oh, it says paracetamol and Panadol. I took Panadol and Panadol. So it's not until they actually go and grab the box, and they think they're absolutely right. And this has happened to me time and time again, that you go through this very basic step, but you can find they didn't take what you recommended. Then you've got to confirm that they took the dose that you recommended, the frequency that you recommended, because they'll say things like, oh, you said to take 2, but I thought 1 was enough. That they may have taken it with food, and many would know now that we say you don't need to take these drugs with food because they are, their absorption is impaired and it doesn't make them more safe, so we prefer that they were taken on an empty stomach. They can take them with food if they want, but they won't work as well. Also, switching to a different NSAID can be useful, making sure they took the drug simultaneously and not alternating, and think about interactions. And then finally, does the patient have realistic pain relief expectations? Because I'm sure you all know, my esteemed colleagues, sometimes people simply aren't getting pain relief because they expected 0 pain. I was going to talk about drug legislation, but I think we've kind of alluded to that already, haven't we?
I think you've kind of covered that to a certain extent. But look, Geraldine, we've actually got quite a few questions been coming in actually. And this one here I think is interesting because it's kind of related to what you're talking about with pain relief. The question is, a patient has been self-medicating their osteogenesis imperfecta with marijuana use, smoking it, and has allergies to codeine and other medications. Their periodontal condition is high risk. Would gummies be an alternative solution to still help with pain management and help lower their perio risk? I don't, not so much concerned about the perio risk thing, but the pain management. I think there's a lot of interest in that.
Yeah, I mean, firstly, the classic line of they're allergic to other medications is the classic line, isn't it, that people use to get the drugs they want. So often, lots of studies shown now that the majority of people using medicinal cannabis are people who would have used it recreationally anyway. So a lot of people not really believing it plays a great role in pain management. If it were to help with pain management at all, it's for chronic pain, not acute pain. So if this person is using it for pain management of their perio, I would say that's probably inappropriate. There are better drugs than cannabis, CBD or THC or both. What's in gummies is usually a teeny tiny weeny dose, so it won't really match up with what they're getting from smoking. Yes, there would be less risk of the periodontal disease because smoking is a risk factor for that, but I think the whole thing is very questionable, and I would suggest that gummies will just give them caries.
And I assume it's not something that a dentist would be recommending anyway, especially for osteogenesis imperfecta. Assuming that's under the care of a medico. Absolutely,
or a paediatric dentist,
right?
Specialist dentist.
Yes, okay. Well, look, thanks so much for that, Geraldine. Absolutely fascinating. Now we have Professor Ian Myers, who's going to take us through an interesting, difficult restorative case. And I've seen the first slide of this presentation, and I want those of you watching just to have a quick look at it and think, how would you treat this patient? Thanks, Ian.
Thanks, Steve, and yeah, it's great to have everyone join us, and hope you're enjoying the content. It's certainly been great for me so far. But look, I thought I'd discuss a little case that often comes to a general practitioner, and it's one of these cases where you're looking at a series of complex situations, and you sort of say, where do I start from here? This one came in because a practitioner, this is a patient who was about 68 years of age. He's just retired, and he wanted to do something about his teeth. He didn't have any posterior lower teeth, and so the dentist decided to give him a lower partial denture, which was lovely and fine, and a very nice partial denture was made. But unfortunately, what happened with that was that the denture was made at the existing vertical dimension, and so in doing so, there was nothing done to the teeth before it started. And if you have a little look at what was there were issues about it. It was a lovely denture, and the occlusion was wonderful, but you've got things like the ceramic coming off a crown on the upper bridge. You've got a lot of worn and cracked teeth anteriorly. On the left-hand side, the clasp on the lower 3 there was sort of sitting on gum level rather than the tooth, and so that meant that there was not a lot of space to put everything else in. So it was a case of, have we done things out of order here? And we sort of need to think about, how do you want to get a good long-term result? And I have a great saying in a lot of these complex cases: you've got to break them down into little bits so you can get through them a bit more easily. But it's also about starting with the end in mind. You've got to think about what you want, how you're going to get there, and go through the stages. Now, obviously, this patient was after a bit of an improvement in aesthetics, but to do that, we had to look at the whole mouth, not just looking at the front 6 teeth, not just looking at his function by giving him a denture at the back. There was also the issue of, we need to have a look at what's the outcome that we want. So I think in this age, whether you do it analog or digital, and I must admit that I really like the digital pathway these days, you can take scans, or you can take impressions, you can do mock-ups, you can do a digital wax-up or an analog wax-up, and you then have an idea about how you want to go. You can discuss this with the patient, you can work out whether or not it's what the patient's looking for. And then I'm a real fan of doing injection molding techniques, what's often referred to as the copy and paste technique. And this is a really nice way of going through and taking the wax up that the technician's giving you. You can take an impression using your clear silicone, and you can use that silicone impression as a stent. And you can go back and then do a build-up of the teeth using that stent one by one. And you can do what we call the alternate tooth technique. And by doing this, we inject composite into each alternate tooth and then swap our Teflon tape around to the alternate teeth. And fairly quickly, we can reproduce that anatomy that was given us to by the technicians. Now, you can see there's been an increase in the vertical dimension. The old denture is now out of occlusion, but we've addressed initially the patient's concerns about what we want to see aesthetically. And the nice part about injection moulding is we have to do minimal adjustment after it's been done, rather than having to try and do these teeth one by one. And then the phase was doing some restoration of the lower teeth. And then, of course, because the posterior teeth on the denture were no longer hitting, there was a little bit of a quick addition of some temporary acrylic onto that denture posteriorly, just to try and get some contact to make the patient more comfortable. At the same time, I did a very quick repair of that upper tooth, which had lost the porcelain off the facing on that bridge, just to make it look a little bit more attractive to the patient, but it was only a minor concern at that stage. But now it was good because we've got a starting point that we can have a look at what do we need to do with the new denture. And then there's another phase here where we've got this broken down lower 4, which needs something built up on it. So it was decided that, because this was going to be a major supporting tooth and there were no teeth behind it, the ideal option was to have that as a good full coverage crown, and obviously designed with a rest seat in it. Now, as much as we love doing ceramics these days, I still love using porcelain fused to metal crowns, and ideally where there's going to be a rest seat on that the denture can sit into. So, of course, going through all the process of making that crown was pretty straightforward because we've re-established the vertical dimension, which makes it a lot easier. So the concept of moving through direct restorative to the indirect restorative and then making him a brand new denture, which fits really nicely onto that crown. And you can see we pretty rapidly recreate the occlusal scheme for this particular patient. Now, obviously you can look at this and say, well, that's single shade composites. It's not maybe adhering to sort of super high level aesthetic dentistry, but we're meeting what the patient wanted in this particular case. It's about getting something that looks a little bit more aesthetic, so that he's got basically conversation distance aesthetics. And, he felt that he, as a post-retirement treat on himself, he'd ended up with a pretty nice improvement from what he'd come from for what he's get. Now, I thought I'd throw in an image of the patient 2 years after I did all that work, and you can see these things can remain quite stable. His oral hygiene hadn't been perfect. As you can see, there's a bit of calculus and things around, so we can talk to him about looking at his oral hygiene, but certainly giving somebody something that's functional, that they're proud of, that they want to keep clean, it then makes someone look after it a bit better. Now, this doesn't stop us if we ever wanted to go into full ceramics. We could certainly do that down the track, but currently, this patient's pretty happy with where he's come. And I think certainly if you think about where he started and where he got to at the end, we've got a pretty nice result. But in this case, it's not a case of let's just jump in and do something. It was about planning. It was about thinking about all the different stages, going from the what do we want at the end, looking at the aesthetics, looking at the function, doing the direct restorations, increasing the vertical dimension, then moving on to the ceramic crown, which was supporting the denture, then making the denture. So the whole lot just seamlessly falls together. And it's not difficult, it's not complex, it's something that most general practitioners can do, and the end result can be very pleasing for yourself and also for the patient. So I think it sort of gives you an idea about the sort of things that we can do restoratively and the need to sort of think about it. And I get lots and lots of questions from patients all the time from dentists all the time about how to manage these complex patients and what's the best thing to do first. Do I do dentures first? Do I do crowns first? So, I think one of the advantages, if you've got a case like this, is give us a call, ask us a question, and we'll direct you down the pathway one way or the other.
Yeah, wonderful, Ian. Thanks so much for going through that in detail. I've got to tell you, as someone who's only practiced oral surgery and sedation for about the last 28 years, when I see that first slide, I know what comes to my mind, but looking at your result, that's an absolutely amazing result. It's something that I think a lot of us look at and just think, wow, where do we start? How do we do that? Now look, while I've got you there, a couple of questions have come in that are kind of related to this. When restoring tooth wear, the vertical dimension usually needs to be increased. How do I determine the amount of this increase?
Yeah, that's a really common sort of question I get asked a lot. And I think I have to be a bit careful here because in a lot of university studies and teaching, there's a fear of anything put into practitioners about, oh, you can't open the vertical dimension, the patient will die. Now, maybe that's the domain of the prosthodontist trying to say that be very careful. But look, I look at this along the lines of when you're replacing some tooth structure and you need to replace lost tooth structure, you've got to create the space to do that. So a lot of the time, the increase in vertical dimension that I'm trying to do for these patients is based on what's required for restorative convenience. And what I mean by that is how much room do I need to restore the teeth to their anatomical shape that they were originally to get the aesthetic result that I want and the functional result that I want. Now, there is no answer. You can't sort of say, oh, I can only open at 1, 2, 4, 5, 6 millimetres. I've had tooth wear cases I've opened 8, 10, 12 millimetres. I've had some I've only opened 2 to 3 millimetres. The big issue is understanding what may happen when you do open the vertical dimension, explaining to the patient that they've lost height. There's no way to replace that lost tooth structure without increasing the vertical dimension and giving them a little bit more room to place the restorations in. Look, as everyone else has said, I give lots of courses on these sort of things where we go through this in great detail. There's a lot of information. I'm very happy to talk to people about this, but it comes down to that initial scan, diagnostic wax up, and working out what's going to work for the patient, how much space you need to do the restorations, and most of the time that's going to determine your vertical opening. Okay,
that's great. And then while I've got to that, one more question. Should I use indirect ceramic restorations or direct composite resin restorations for the rehabilitation of tooth wear cases? I think you've shown you probably use a combination, but what's your answer to that?
Yeah, look, I think the long and short of it is there's a lot of risk with going straight to ceramics. There's some recent publications reviewing this, and the general consensus across the literature now is composite before ceramic. So you get your patients, you restore with composite resin, you establish your vertical dimension, your aesthetics, you ensure that's all right, then it's a very easy transition to ceramic. The problem with jumping straight into ceramics is it's a big cost, big time, and big chance of failure if you get it wrong. So I would definitely say start with ceramic. If you need start with a composite. If you need 1 or 2 ceramic, that's fine, but certainly don't start with a full ceramic rehabilitation. The real message here is do a composite resin rehabilitation first and then transition to ceramic when required.
Okay, well, thanks so much, Ian. That's fantastic. There are other questions, so hopefully we'll get time at the end for those. Now, I'd like to introduce Dr. Manu Iyer, anaesthetist. I know how good an anaesthetist Manu is. He's been my anaesthetist for many years, and he's going to talk to us about something that I hope none of you ever have to experience, and that is how to handle a severe allergic or anaphylactic reaction. And most interestingly, he's going to talk about a case that involved someone very close and dear to him. So thank you, Manu.
Thank you so much, Steve, and thanks for everyone who's joined us today. Anaphylaxis is an acute, life-threatening multi-system syndrome. It's mostly because of eosinophils releasing histamine, which causes a lot of the symptoms. It can lead to upper airway obstruction, respiratory distress, cardiovascular collapse, as well as cardiac arrest. If you suspect anaphylaxis, please call the emergency services and administer adrenaline IM. In a population study, anaphylaxis is most commonly in males between the ages of 0 and 4, and in females between the ages of 25 and 34. Fatalities are about 0.7%, and it's mostly in young Is it anaphylaxis? A number of different things can happen on a dental chair that look like anaphylaxis. Vasovagal syncope, hypoglycemia, angina, seizures, and hyperventilation. They all look like anaphylaxis, but they can be differentiated. Anaphylaxis is fairly rare on the dental chair. When we look at the incidence of perioperative anaphylaxis, it's in the order of about 1 in 10,000, and the mortality rate in the operating theatre is about 4%. These are the other conditions that look like anaphylaxis: vasovagal syncope, anxiety or panic attack, hyperventilation, as well as acute asthma. The way to differentiate it is none of these have skin symptoms such as urticaria, flushing, or itching, nor do they have respiratory symptoms such as angioedema, upper airway swelling, or bronchospasm. One of the most specific things about anaphylaxis is in about 50% of patients you get gastrointestinal findings, nausea, vomiting, crampy abdominal pain, and again, none of these other ones have that. I'm just going to spend a bit of time on this slide. So anaphylaxis, as I said, is multisystemic. In about 80 to 90% of patients, you will have skin involvement with itching, flushing, urticaria, angioedema, conjunctivitis, and a runny nose. About 50% of patients will get cardiovascular side effects of tachycardia and hypotension. Some people will get chest pain, as well as other arrhythmias. About 70% of patients will get respiratory involvement, including stridor, tongue swelling, uvular swelling, bronchospasm, as well as cough. And as I said, one of the most important ways of differentiating it with other things that are happening on the dental chair will be the incidence of GI side effects. Nausea, vomiting, and crampy abdominal discomfort happens much more commonly with anaphylaxis than the other syndromes that I mentioned previously. These are the things that cause anaphylaxis on the dental chair, or for dentists: antibiotics, analgesics, antiseptics, especially chlorhexidine mucosally, some sedatives, local anesthetics, mostly as sodium metabisulfite in the solution, some endodontic formulations which have formaldehyde and sodium hypochlorite, things that we use for impressions, alginates, and items with latex in it. Sorry. In general studies, 20% of anaphylaxis in human population is with insects, 30% is food allergies, about 35% of allergies is medication related, and 15% is related to topical things like environmental things like latex. The incidence of mammalian meat allergy has been increasing, especially on the eastern seaboard in Australia. It's to a product called alpha-gal, and there's a number of things that dentists use that we can't use if a patient has got meat allergy. Topical gel, prophy paste, topical fluoride paste, catgut sutures, collagen membranes that we use for bone grafting, gel foam, and recaldent.
Can I just ask, Manu?
Yes.
Now, you're going to talk about a case that happened to someone very dear to you, which, of course,
Yes.
was yourself.
Yeah.
I believe it actually was that.
Yes.
Can you let people know exactly what you experienced?
I got bitten by a tick last year, and I went to one of the best restaurants in Japan to have Wagyu beef. Unfortunately, 2 hours after I had the meal, I had, if you just go back to the, I'll just go back to this slide, and I had nearly all of them. I was lightheaded and confused, but that's probably a normal state for me. Respiratory wise, I had very significant stridor and bronchospasm. I had a swollen tongue. I had tachycardia, hives all over my skin, especially my chest, and crampy abdominal pain. Lucky the people around me helped me out, and the medical professionals actually saved me. Yeah, it's actually quite a florid reaction, and something you don't forget. And I hope, as Steve said, I hope none of you have to deal with it on the dental table.
Did you get quite panicky? You know, did it
Yes.
lead to that kind of
Yes, you do. You
extreme
do
fear?
get quite panicky because you
Yeah.
can't breathe.
And what did they actually give you to treat that? Did you actually have to have
just-
adrenaline?
Yeah.
They
you
actually
do
gave you adrenaline.
I am adrenaline
In the restaurant or when you got to hospital?
in the hospital.
All right.
In the hospital.
Can
Okay.
can I just ask, what was the time period between your tick bite and the...
It was actually about 3 hours.
No, between the tick bite and
Oh.
going to the restaurant and having Wagyu
That was
beef.
about 6 months.
All right.
6 months. But by the time I had the Wagyu beef to the reaction,
Yes.
it was about 2 to 3 hours.
Oh.
Okay.
So it wasn't immediate, but I could feel it building up, and then it happened.
So you were no longer in the restaurant? You'd gone somewhere
Yes,
else?
I was on the metro in Tokyo.
Okay.
Not a good place to have anaphylaxis.
No.
Just talking about anaphylaxis to local anesthetics, it's probably not the local anesthetic molecule that patients are allergic to. It's the sodium metabisulfite, especially solutions that have adrenaline in it. That's the moiety that people are allergic to. The other thing I would like to mention is IV adrenaline, if we accidentally inject it while numbing the jaw, a lot of the symptoms that patients can get can look like anaphylaxis. So people need to be careful when they're injecting local anesthetic. Aspirate before you inject. When does it happen? Anaphylaxis can happen in several minutes to several hours after the exposure to the agent. IV administration causes an earlier onset, a more severe reaction, which is to be expected. And one of the things I'd like to actually mention is when we use endodontic disinfectant and sealant, especially with formaldehyde, the reaction often in over 50% of patients, if they're going to react, is from 2 to 12 hours after the initial contact. So patients probably need to be told about the symptoms to look for and contact medical professionals if required. I want to spend a couple of minutes on this slide. Anaphylaxis, what are we looking for? We're looking for skin signs, hives, itching, flushing, angioedema, and swelling of mucosal tissues associated with sudden respiratory symptoms, which can be shortness of breath, wheeze, coughing, stridor, or hypoxemia, with suddenly reduced blood pressure and signs of end organ dysfunction, especially associated with GI symptoms, as I said before. In infants, anaphylaxis often looks like just a bit of pallor, and they're just not themselves, and a low systolic blood pressure.
Can I just ask, Manu,
Yeah.
I've heard many times that you don't necessarily get the rash, though, do you? It's not in every
Yeah.
case, so it's
For
not
sure.
something. Yeah, it's
For sure.
just-
80 to 90% of patients with anaphylaxis will have a rash or some kind of skin symptom or sign. But in about 10 to 15%, there is no skin
Right.
signs. Some people will just have one system things, such as hypotension or bronchospasm.
Right.
But if you suspect anaphylaxis, the treatment is intramuscular adrenaline. It's the only thing that's been shown to decrease mortality, and it's the only thing that works in an acute anaphylaxis. That's why adrenaline is in this halo here. It works in a number of different ways. It decreases the release of histamine and mast cells in eosinophils. It decreases bronchospasm. It causes a decrease in the mucosal edema that's causing the stridor. It is a positive inotrope and chronotrope, so it increases blood pressure and venous return. And all these things actually are therapeutic because it antagonizes the histamine, which is doing all those things that are causing problems. Adrenaline is administered intramuscularly in the anterolateral thigh, like that child's doing in that photograph. The initial dose is 0.01 milligrams per kilogram to a maximum dose of 0.5 milligrams in adults and 0.3 milligrams in children. About 30% of people who have anaphylaxis require 2 or more doses of adrenaline during the attack. So in practical terms, if you've given an IM dose of adrenaline and the symptoms are not resolved in 5 minutes, the patient should probably get another dose. There's been a recent study of dentists and what they know about adrenaline in anaphylaxis. About 14% know the dose of adrenaline to use. 40% know the administration route, and 25% knew how to use an EpiPen. There's other treatments for anaphylaxis. Suffice to say, the take-home message from this slide is antihistamines and glucocorticoids as initial treatment for anaphylaxis is not recommended. This is what I'd like to tell everyone who runs a dental practice. Each practice should have an emergency protocol for anaphylaxis. Hopefully, they'll run simulations for their staff so they can deal with anaphylaxis if it ever happens. And at the least, every practice should have an EpiPen or ampules of adrenaline for use in an emergency.
Okay, great. Well, thanks, Manu. I just want to go back to looking at the dose. Well, yeah, you can go back to it. I think you said they're 0.01 milligrams per kilogram, but in the end, most of us won't be drawing it up and weighing the patient, doing all this. Yeah. So they will have an EpiPen. Now, can you just run through the different types of doses that are in the EpiPens and when you would use them? Are they different for children? Are they, compared to adults? So what do we have available?
So there is pediatric EpiPens and adult EpiPens.
And what doses are they?
The adults can 0.25, 0.5, or a milligram, which is a big dose. So in an average size adult, you can just crank it up, rotate it to 0.5 milligrams and then press a button and it'll give you the pre-metered dose. In children, the dose is 0.15 and 0.3. So
right. Okay. And
Can I just also say there's two brands, aren't there?
Yeah.
So people need to also make sure they know
which
the
brand
technique.
they have,
yeah, because it's different techniques for the different brands.
Which is part of the training that you're saying. So there's only a couple of medical emergencies where you really need to do something, give something, cardiac arrest, for example, and anaphylaxis, and that's not the time to be trying to work out how to use the actual equipment and how to use it the first time. And that's also why having little ampules that you need to break and then draw up, if you don't do that on a regular basis, you're not going to do it that first time in an emergency. I've seen people get there and they're dropping the first one, they crack the second one, and they cut themselves. So that's why an EpiPen is good. Unfortunately, they're not the cheapest thing, and they, the lifespan of the thing, expiry date is not terribly long, but they're absolutely essential to have in that situation. Okay. Just as an aside, I did talk to another anaesthetist a while ago that we both know, and she was an anaesthetist for quite a long time, and she said for the first, I think it was about 12 years of her practice, she had never had an anaphylactic reaction, never had one, until the day she did, and then in that year she had 3, with one of them being an absolutely major one, and she was in the ambulance all the way to Westmead Hospital, and she was repeatedly giving these about every 5 minutes. She doesn't even know how many that she went through in the end. So one final question. I suppose a dentist, if they actually had a patient who did develop severe allergic reaction or verging onto anaphylaxis, the first time they're going to use this, they're going to be nervous. What effects is the patient going to report that they should expect, headaches or anything like this, heart rate, palpitations, what is it that the patient's going to be complaining of from the adrenaline?
The patients will complain of feeling unwell, itch, difficulty breathing.
No, I'm talking from the adrenaline itself, though.
Once they get the adrenaline?
Yeah.
Depends on how sick they are when they're getting the adrenaline. If they're really unwell, they don't really notice the side effects of adrenaline. They'll notice if it's a mild anaphylaxis and they get a dose of adrenaline, they'll notice the tachycardia, the heart pounding in the chest, and they'll feel that their breathing gets better. So the sicker you are, the less you notice the side effects, but you do notice the tachycardia and the heart pounding in your chest.
And don't you feel really tired afterwards as well because you just run a marathon?
Yeah. Okay. Well, look. Yeah, I just wanted people to know that if you need to use it, you use it. Okay.
It's on if you suspect anaphylaxis, you should use adrenaline and then worry about it
afterwards.
Yes,
okay. Well, look, thanks so much, Manu. That was fantastic. Now we have Dr. Amanda van Nieuwen, who's going to discuss some interesting cases and how to handle them. So thanks, Amanda.
Thank you very much. So one of the biggest conundrums I think practitioners face is when to actually refer a potential malignancy or pre-malignancy, and the consequences of a missed diagnosis or a delayed diagnosis can be severe. April is Oral Cancer Awareness Month, and while the Dental Advice Network will be here for you for your oral medicine related queries as well, I'm hoping that discussion of some of these cases will empower clinicians to know how to take quick action if required. So what I'm going to go through now is a few different clinical photographs, and I'm going to go through them fairly quickly. But what I really want you to do is just have a look at these cases and think what you would do. Would you ignore these cases? Would you document and review? Would you offer referral, or would you refer urgently? So this one here is a lesion involving the patient's lateral tongue. Another lesion involving the patient's lateral tongue. A crusted persistent lesion involving the lower lip vermilion. An area of numbness involving the patient's lip and face. And a swelling involving the patient's floor of mouth. So head and neck cancer is increasing, and it has been increasing for a while. Particularly cases of oropharyngeal cancer are also increasing. You may have heard in the news that cases of head and neck cancer are falling. And the reason that you have heard that is because they have not properly defined what head and neck cancer is. Cases of lip cancer in Australia are falling, largely due to the fact that we're much better with slip, slop, slap, and the sunscreen. However, if you take out lip cancer from that, oral cavity and oropharyngeal cancers are increasing. Now, the cancers, when we talk about them for this presentation, or usually in general when we talk about them, we are generally talking about oral squamous cell carcinoma, oral cavity squamous cell carcinoma. However, we should remember that there are different types of cancers as well. So your squamous cell carcinomas are talking about cancers that originate from the epithelium of the oral cavity. But you also do have salivary gland tumors, lymphoma, odontogenic tumors, metastases, sarcoma, and melanomas. So don't forget that there can be a very wide range of signs and symptoms. One thing I do want to emphasize is that there's no such thing as a silly referral. And in the context of Dan, there is no such thing as a silly query. All of these cases here that I'm showing you, they all needed a biopsy. I'm not expecting you to diagnose squamous cell carcinoma based on looking at the clinical photographs. However, these photos should trigger something in you which should reflect that the patient should be further investigated. So just for your information, the one that was the squamous cell carcinoma was the lateral tongue photo on the top right, but I biopsied all of these cases because they needed to be investigated further. So what are some of the oral cancer red flags? And there will be a table, I'm sure, in the new therapeutic guidelines as well. In general, the things that we're looking for are anything that has persisted without a known cause. So an oral ulcer that has persisted for longer than 2 weeks, ulcers that do not have a clear cause, localized pigmented lesions of the oral mucosa, and any sort of red, white, or mixed or ulcerative lesion that is indurated, fixed, has rolled margins, isn't healing, you don't know why it's there. It involves a high-risk site of the mouth, which is basically the floor of mouth and the tongue. Some other signs to look out for will be facial or oral paresthesia. We don't like things going numb randomly. Pain with no obvious cause, lymphadenopathy, signs of salivary gland disease, and individual patient risk factors as well. So immunocompromised patients or medically complex patients, patients with a family or self-history of cancer, because don't forget cancer can metastasize, and if they have non-specific symptoms like fever, malaise, or unexplained weight loss. So this here was a patient that came in with an ulcer involving her floor of mouth, and these were the red flag signs. It was persistent, it did not heal after several weeks. It was involving a high-risk site, so we are looking at the floor of mouth. It was an ulcer with a rolled margin, which you can perhaps see more anteriorly. You can see that rolled margin. And you can't necessarily tell this from the photograph. You can tell it by palpating the lesion, but I can tell you that it was fixed to the underlying tissues and it did feel indurated. So it was firm, it was hard. Now, with these cases here, they are all tongue cancers. It's not going to be difficult to pick up a lesion if you see the photographs on the left-hand side with these obvious tongue lesions. But our goal and what we really want to do with early diagnosis to improve a patient's prognosis is to detect them when they look like the cancers on the right-hand side. So our goal is really to catch pathology early. So I did a podcast with a friend of mine, Dr. Annalene Weston, before for dental protection. And one of the things that we did discuss was that there were more cases of missed oral cancers in Australia. And we don't really know why. And we sort of talked about it a little bit. Perhaps it could be that clinicians were feeling that it could be a silly referral, or they didn't want to worry their patients unnecessarily. But I can tell you that missing a diagnosis or having a delayed diagnosis is worse for the patient. So back to those cases there, what to do. I think it's going to be a little bit of a no-brainer. These were cancer cases and they should have been referred urgently. So this one here was a patient who had a persistent nodule involving his lateral tongue. He was a country patient and he didn't really want to come up to Perth. So this unfortunately did end up being delayed for a little while, but fortunately it was an aggressive cancer that grew quickly, so he recovered with white local excision. This one here I thought was a really interesting one to include as well, because I wondered how many clinicians would look at this and think it was just something like a fibroepithelial polyp and leave it. This actually was a early squamous cell carcinoma, so this one should have been referred as well. And that's the more views of that little polyp on the side of the tongue, which was a squamous cell carcinoma. This one here, I would actually say that the patient should have been referred urgently because it has plenty of red flag signs. Any sort of areas of persistent firmness, crusting, or ulceration that has persisted for longer than 2 weeks should be checked out. And one of the tips that I would like to give you is that if you are referring a patient urgently, don't forget to call the specialist rooms to let them know. Particularly in oral medicine, and I'm sure in other specialties as well, we do triage patients based on the patient's photograph and presentation. So sending your photographs together with your referral and calling the specialist rooms to let them know that you're sending something that's potentially urgent would be really helpful. And this one here, again, was a malignancy, should have been referred urgently. And this one was a lymphoma. And you can see there the green arrows. Now, I would like to just finish off by sharing one of these cases where a patient came in to see me and there was no referral. So the patient wasn't actually officially referred in, although they were told. So what happened was that a year ago, the patient saw a dentist and something was noted involving the left floor of mouth and lingual gingiva. She was undergoing breast cancer treatment at the time, and the dentist told her to mention it to the oncologist. She mentioned it to the oncologist, who didn't seem that bothered. She wasn't that bothered because the dentist had looked at it and she mentioned it to the oncologist like she had been told. She finished her breast cancer treatment and she went back to the dentist a year later and she was told verbally to go see an oral medicine specialist as soon as possible. She and the area felt like it was bigger, it was rough, and it was bleeding. So unfortunately, it was a squamous cell carcinoma when I biopsied it, and I sent the patient to a multidisciplinary clinic, which is what we do with our oral cancer patients. And unfortunately, her case was surgically unresectable, not curable, and the recommendation was for palliative care. The reason why this patient and her story has stuck with me for so long is that I cannot help wondering that if things had been done properly, if she had a proper referral, things had been checked out a year earlier, if her prognosis would be different. All right, so final message: if in doubt, check it out. If unsure, err on the side of caution.
Okay, well, thanks, Amanda. Some very sobering thoughts there, and that was an excellent presentation. Look, we're about to take a short 1 minute break, but don't even think about going anywhere. I've just seen some of the questions we've got coming up. There's some crackers amongst them. So I'll be putting that to our panel in just over a minute. Be right back.
You know the feeling. You sit down with a new patient, ready for their initial exam, and they hand you a medical history that reads like a novel. Pages of unfamiliar syndromes and medications you can't even pronounce. You look in their mouth. How do you treat those severely worn down teeth? And what about that asymptomatic tooth that appears to have an apical radiolucency? What's the next step? The Dental Advice Network provide timely, practical and expert advice to all members of the dental care team, including dentists, hygienists and therapists. Dan's online helpline is your direct access to trusted, clear advice from the people who know their fields best. In addition, Dan offers online resources, webinars, and even step-by-step instructions for writing scripts commonly required in dentistry. Why struggle alone? Let Dan help you simplify complex cases, minimise risk, and provide safer, more effective patient care. Subscribe today at dentaladvicenetwork.com.au.
Okay, well, welcome back. Like I said, there's a couple of great questions here. Now, Amanda, seeing as you've just spoken, we're going to direct them straight to you. Should general dentists be performing oral biopsies?
So I think that a general dentist is capable of performing a biopsy because the biopsy procedure itself is not hard. I mean, if you can do a surgical extraction, chances are that you could do a biopsy. But the issue is knowing where to biopsy, how to interpret the results, and what the clinical correlation is with the histopathological findings, which general dentists are not trained in. So in general, I would recommend against it. I don't really think that there is a good reason for a general dentist to perform a biopsy without additional training, because there is just too much that could go wrong with giving the results, interpreting the results, and managing the condition, really.
Okay. And kind of related to what you were just saying then, this is an interesting question. Can we use the word cancer to the patient we are seeing for the first time if we suspect a tongue ulcer could be an SEC?
So this is a very common question that I do get. And I would like to share a story that happened to me when I was a registrar training in oral medicine. So I had a patient who came in and I thought he had a cancerous lesion. I didn't tell him it was cancer, but I told him that it was serious, and I got him to come back for the biopsy because for various reasons we couldn't do it that day. The patient never came again, never came back to me. And I had a senior UK consultant at the time who was actually visiting, and he told me that it's much better to educate the patient and to let the patient know the truth than to go the other way around and for the patient to then not show up. Because then I always wondered if I had actually told the patient that I thought it was cancer, if he would show up. So in general, you may want to temper your message a little bit, because if you have a highly anxious patient, you might want to deliver it more gently. But it is much better for the patient to leave your clinic thinking that they need an urgent appointment with a specialist than for the patient to leave your clinic thinking the dentist didn't seem that worried.
Okay, great, thank you. We've had some other interesting questions here. I think this one's for you, Ian. Just silver fluoride as a caries arrestor, ?
Yeah, that's a really good one, and I have to say that I'm a great fan of silver fluoride, having not really been taught a lot about it in my university days. It was very much a state-by-state based thing, but in more recent years, it's become basically the standard care for high caries risk patients, particularly the older patients. The issue people have with silver fluoride is that, yes, it turns the teeth black, but it is the best way for managing the open, cavitated, aggressive caries lesion. Now, there are a couple of provisos to that. I think the thing to say here is that silver fluoride isn't the answer to everything, but for patients that may have limited cooperation, patients you can't maybe manage easily, or there's a large amount of gross caries, it's a really good intervention for slowing down the progression of caries, particularly root surface caries, particularly early childhood caries. For your everyday patient, you're probably not going to use it for small amounts of caries. This is for more the aggressive caries that you get. But certainly silver fluoride, there are a couple of different formulations out and about now, and there's more and more of these coming out. But I'm a big fan of using silver fluoride. I think it works particularly well. And you can use it with what we call the SMART technique, the silver modified atraumatic restorative treatment. Using silver fluoride in conjunction with using glass ionomers and glass hybrid materials can form a really good way of stabilising aggressive caries and slowing it down, so you've got more of a chance of saving the tooth.
Okay, well that sounds like a bit of a wrap for the fluoride, the silver fluoride. Now look, this one's for you, Geraldine. They say that non-steroidals can increase blood pressure. Is this blood pressure increase significant? How quickly does it occur? And is it relevant in dentistry since we only prescribe NSAIDs for a few days?
It is relevant, actually. The studies have shown that the degree of blood pressure elevation can be anywhere from 3 to 5 millimetres of mercury, and that can occur within about 5 to 7 days. So what really matters is who's the patient, because if it's a young female person, and as you may know, most young females have got low blood pressure, I don't think anyone cares, because they'd probably be happy to have slightly higher blood pressure. But for someone who's got more critical blood pressure, or maybe it's been fluctuating lately, or they've been having high readings lately, then that would be an important elevation in their blood pressure. So you can't just judge it on the drug alone, you would judge it on who the patient is and how they'd go in those 3 to 5 days.
Okay, well thanks for that. So it is significant. Omar, I think this one would be best directed to you. Someone just said, I can't fully anaesthetise lower molars with pulpitis. As an endodontist, I'm sure that you've had your fair share of difficult to anaesthetise lower molars. So what advice would you give in that situation?
Oh, this is quite a good question. Probably throw this on over to Geraldine as well. It's ibuprofen I really like, at least 600 milligrams 1 hour preoperatively. And if you can get a fast-acting one, that's a really good thing to do. I also do a lecture on this about emergencies, which I'm actually going to do this Thursday night, so there's a bit on that. But I really like the idea of using articaine as an infiltration because it's got a thiophene group and it helps to diffuse through the nerves and the soft tissue better than lignocaine. That's another helpful local anaesthetic to use. So that's my kind of regime for lower molars.
Actually, I've heard from a lot of endodontists I've talked to, they use articaine.
Yes.
Quite extensively, actually. They say that they really do notice the difference. Okay, well, thank you for...
Can I just clarify something?
Yes.
Because Omar mentioned fast-acting ibuprofen. Do you mean fast-acting versus sustained release, or do you mean fast-acting versus slow? In our household, we call it fast and slow ibuprofen. You know, the what do they call it? Nurofen Smart. Zavance, that's it.
Yeah, like the fast acting with the
Do you mean
with the
that?
different coatings. So the
I don't think they make much. It's like
gel
a minute.
a gel cap versus like the harder capsules.
Yes.
Have you actually
Or
looked at the
the-
studies that show the difference in timing, though, of
I
absorption and onset?
was thinking that it was around about 25 to 30 minutes over like the hardened ones you get from Woolworths, but you don't think
It's
it makes
not.
a difference?
No, it's like 2 minutes.
Oh, really? Is that all?
Yes. Because the reason why I mentioned it is that there is sustained release ibuprofen
okay.
in New Zealand. And I have seen some studies, often coming from New Zealand, where they use sustained release ibuprofen for their preemptive
And it's
analgesia. No,
It's worse.
it's not going to work until the operation's over.
Right.
You do want the fast-acting
Yes.
one, but I don't think it would matter whether you use Zavance or slow
doesn't
ibuprofen.
matter, okay.
No, just normal ibuprofen is fine.
But the main message is ibuprofen beforehand to try and minimise
Yes.
that.
Yeah.
Okay.
Yeah, and also I like the use of just you give it to the patient as soon as you see them, and then you have to send them away because, of course, often they're emergency patients.
Right.
Don't get them to drink coffee, obviously, downstairs
Okay.
because their tooth
me?
is sensitive.
Okay. So, Ian, another question for you. Do you issue a night guard after increasing the VDO to maintain the restorations?
Yeah, again, a really good question. It depends on the case. I certainly don't use a very thick splint because I've already opened the vertical dimension quite a bit. I suppose the only time I really want to use a night guard is if the patient has got some severe clenching, bruxing problems, or if I'm worried that they're going to break my restoration. So it's a bit of a safety thing there. But look, generally, I've done a bit of an occlusal analysis with my diagnostic wax up. I've worked out what my cuspal inclines are going to be, what my overbite overjet's going to be. And I usually would say that 80% of the time I don't give them a night guard. If anything, it's going to be a very thin, pressure-formed, hard splint, which can just protect the restorations. But I've already basically given them a splint, which is just a fixture in their mouth now. Rather than having a removable acrylic splint, they've got a fixed composite resin splint on their teeth. And if you get your occlusal scheme right, it becomes a splint for them. So only if it's very deep overbite overjet, only if they've got a strong occlusal load will I make them a splint or a night guard.
Okay, great. Well, thanks very much for that. Look, I think time's getting away from us. but it's been absolutely wonderful. Sorry if we didn't get to your question, there's just so many there. So look, I don't know about you, but I've had a great time tonight discussing these cases and issues with all of you. So don't forget that if we didn't get to your question, DAN members have direct access to all of us whenever you need via the members only section on the DAN website, which is www.dentaladvicenetwork.com.au. Now this evening we're offering a discount code exclusively for those who tuned in tonight, and you can find the link for that at the bottom of this page. So don't miss your chance to get DAN membership at that discounted price. Look, from all of us here this evening, thank you for tuning in, and we look forward to seeing you for episode 2 of DAN Live, which will be a members only event. So thank you again for tuning in, and good night.